Hello, everyone, and welcome back to the last session today. I am very happy and very honored, actually, to welcome the next two speakers, Michel Shamy and Alex Sutton. They have both, for several years, published very interesting papers and made a lot of interesting work related to an evidence-based research approach. So it's a great pleasure to welcome the two of you. Thank you for joining us. And the first speaker will be Michel Shamy, who is a neurologist and researcher based in the Ottawa Hospital Research Institute of the University of Ottawa in Canada. His research explores ethical, epistemic, and clinical issues in stroke care with a focus on the ethical justification of randomized clinical trials. Thank you so much, Michel, and the time is yours.
Thank you very much, Dr. Lund and the organizing committee for inviting me to speak today on the topic of equipoise and evidence-based research. I have no conflicts of interest. I have no connections to industry. The work I'm going to be discussing today has been supported by a number of different groups, including the Canadian Institutes of Health Research and the Heart and Stroke Foundation of Canada. My most important disclosures relate to the fact that the work I'm presenting is not only my own, but is in fact the work of a team, with prominent members being my friends and colleagues Mark Fedek, a philosopher of science now at University of California, Davis, and Brian Dewar, a research librarian who is my right-hand man when it comes to this work. I'm also the father of two small boys, and I use their art to illustrate my presentations, so you'll be seeing some of that in the background of the slides. Let's start by giving you an overview of issues of ethics as pertains to this question of equipoise and evidence-based research. It's generally accepted that physicians owe a fiduciary duty to their patients to provide the best possible care. Physicians should not be doing things that put their patients in harm's way or provide them with worse than standard care. It's also recognized that enrolling a patient in a randomized clinical trial potentially threatens that duty, in that patients may receive the treatment that is ultimately found to be inferior. Now, there are a number of responses to this potential dilemma in the literature. One of them is to say, don't worry about it. Physicians and researchers don't owe patients the same duties. When you are a researcher, you're not concerned with the outcome for that individual patient in front of you. You're concerned about gathering knowledge to aid in the treatment of future patients, and so you can't make an omelet without breaking a few eggs. An alternative view is to say that because of this potential threat to the physician's fiduciary duty, RCTs are always unethical and should be abandoned, and I think that really is a non-starter in the modern climate of evidence-based research. And so I tend to be most sympathetic to the view that, you know what, RCTs are risky. They do put patients in harm's way, but I think that we can figure out a way to navigate our dual responsibilities as physician and researcher and provide patients with care that is acceptable. It probably goes without saying, but maybe not, that a clinical trial would be unethical if it's harmful to patients, and we should generally avoid unethical studies. And so determining whether a study is unethical is at least in part a scientific question. So a trial can be unethical for a number of different reasons. You could, violate consent, you could take advantage of patients, etc. But if the trial is scientifically poor, if it is not of good scientific quality or is based on poor evidence or is unnecessary on the basis of available evidence, then it's definitely unethical. So the ethics review of a study should have a strong scientific component. As I've alluded to, the state of background knowledge seems to be quite important in determining if a trial is acceptable or not, because we probably shouldn't know a priori, ahead of time, if one of the treatments is clearly inferior to the other. We shouldn't be giving patients a treatment that we know to be inferior. So how do we know if a treatment is inferior? Well, some would argue that we can't know without doing an RCT, that the only knowledge that is trustable, that is trustworthy, is knowledge derived from an RCT. This is the paradox of EBM, that some have argued that the absence of an RCT is the justification for doing an RCT in and of itself. I happen to think that this is nonsense. I suspect that many of you do as well. So there should be a way to figure out what evidence we need to have and what evidence we need to not have to decide whether a trial is acceptable. And this is important because if we can't reliably differentiate between an ethically justified trial and an ethically unjustified trial, then we're putting patients at unnecessary risk, we're wasting valuable resources, and we're threatening trust in the scientific enterprise as an entity, as a whole, which is certainly something that we can't afford to do now in the era of anti-vax, anti-mask, etc. So this question of what evidence we need to have or not have is referred to in the philosophy of science as the evidential problem. The common response to the evidential problem, at least in the medical literature, is to cite equipoise. And this is something that we encounter as a concept in the literature and as a concept in regulatory documents. For example, the Canadian Tri-Council Policy Statement on Research Involving Humans states that, quote, equipoise should be considered as a starting point for the design and review of clinical trials. And US regulations also cite equipoise, but what is it and how does it solve this evidential problem? So this is the bottom line. This is what I'd like you to take from this presentation. Equipoise is a term used in relation to several different concepts, several different ideas, each of which, and which put together, represent a weak, inconsistent, and non-transparent standard by which to evaluate the ethics of randomized clinical trials. Why does it matter? Because the ethical justification of RCTs is a real problem for evidence-based research. We can't do good research if the ethics aren't figured out, and the ethics are an issue for evidence. And fundamentally, it's a problem that I think could be answered through developing a rigorous evidence-based approach to research. Let me give you an example from my clinical life as a stroke neurologist. Up until the mid-1990s, there was no acute treatment for stroke. Then we had a number of RCTs demonstrating benefit for thrombolytic, a clot-busting drug, TPA, alteplase, all means the same thing, a drug given in the vein that could melt a clot that had formed in the brain that was occluding an artery, causing stroke symptoms. TPA was a very good step forward, but it was not does not open all arteries. Not all patients are candidates, so we needed something more. Attention turned in the early years of the 21st century to endovascular thrombectomy, procedures using wires and catheters, etc., to go up into the brain and use various devices to ensnare or trap or capture the clot and pull it out. What you see here is what's called a stent retriever. It's a wire mesh that essentially opens around and through the clot and can be used to pull it out. Now, endovascular thrombectomy was used widely, seemed to be quite effective, but as of 2012-2013, there was no RCT evidence to support its efficacy above standard treatment. And then 3 large randomized trials, multi-center, high-quality trials, published in the New England Journal of Medicine, came out showing that EVT, or endovascular thrombectomy, was not superior to standard treatment. Despite this, there was a community of people who were using it very frequently, experts in the field, who were very strong believers in the efficacy of EVT, and said, we need to prove this in a trial, we need to do another trial. And yet, there was a significant ethical debate in the literature, in the community, because some experts were arguing that doing another trial would be unethical. Why? Because we already have 3 trials showing it's ineffective? No, that wasn't their argument. Their argument was that despite the trial evidence, we know it's effective. We don't need to do another trial. It would be unethical to randomize patients away from a treatment that has become standard of care, despite the fact that we have no RCT evidence, and in fact, RCT evidence to the contrary. I was a stroke fellow in Calgary where they were designing the ESCAPE trial, which was going to be one of the next generation of trials looking to establish the efficacy of endovascular thrombectomy. And in the middle of this controversy, my supervisor said to me, Michel, you're interested in this ethics stuff. You figure out this problem for us. Well, 8 years later, I haven't figured out the problem, but the trial was done. It was completed. It was successful. It did prove that endovascular thrombectomy was superior to standard treatment, and it was published in the New England Journal of Medicine. Sounds great. Except if you think about the individual patients. So here's an example of a true patient who was a candidate for the ESCAPE trial. This is a 38-year-old woman, a mother of 2, who has a congenital heart condition for which she takes blood thinners, anticoagulants. She presents with a major stroke. There is a blockage in her left middle cerebral artery, the kind of blockage that would be amenable to treatment with endovascular thrombectomy. Because she is on blood thinners, she cannot receive TPA, the thrombolytic, and so her only acute treatment would be thrombectomy. Should she be enrolled in the trial, where she has a 50% chance of getting thrombectomy and a 50% chance of essentially getting nothing, versus not enrolling her in the trial, where she would have a 100% chance of getting thrombectomy? Well, if you believe in the efficacy of thrombectomy, that's a big problem. If you, however, believe that, well, we don't have RCT evidence to prove the efficacy of thrombectomy, then it might be a reasonable thing to do. This patient was enrolled in the trial. She was randomized to receive standard treatment, essentially no treatment. She had a massive stroke. She died. Her 2 children were left motherless. Was this necessary? Might a better approach to the evidential problem have helped us to avoid a circumstance like this? So if equipoise is our answer to the evidential problem, let's dig in. The concept of equipoise, the term, was introduced in 1974 by American legal scholar Charles Fried, this man down here on the right, who argued that randomization is only ethical when the treating physician does not have a preference for one of the experimental therapies. That as soon as you, as the treating physician in charge of that patient in front of you, believes that one of the treatments is superior for that patient, then you are obliged to offer it. So in the case of our young woman, we would not have had equipoise. We would not have enrolled her into the trial. Sounds like a convincing argument, except that there are very obvious objections that somebody like Rumpole of the Bailey would point out to us. Doctors almost always have preferences, especially those who claim to be experts. And yet those preferences are not always correct. We know that from the history of medicine. And they're highly influenced by psychological, cultural, administrative factors. Moreover, there's a big problem with this standard of equipoise, which is that 2 different physicians looking at the same patient could arrive at different answers. And that makes this a not standardizable, not transparent, not universal criterion to use. In response to many of these criticisms, McGill University bioethicist Benjamin Friedman introduced a widely influential revision of equipoise in 1987, when he argued that it's okay for individual physicians to have preferences. In fact, we should expect it. And it is the presence of those preferences leading to disagreement within a medical community that is the ethical justification for doing an RCT. You can only do a trial if there is disagreement, and the study should be designed in such a way to replace that disagreement with consensus. Now, this is the most cited standard for clinical trial ethics, at least in North America. I know in the European context, Fried's version of equipoise, which is often called the uncertainty principle, is quite popular. But in Canada and the United States, we hear a lot of this Friedman equipoise version. Now, a very skillful interrogator like Elizabeth Warren might identify that this concept has a number of holes. Friedman didn't tell us. How do we determine whether disagreement exists within a medical community? How much disagreement is necessary to justify an RCT? Who is the relevant community? Is it doctors in general, neurologists, stroke experts, patients? And in reality, how often does one RCT on its own produce consensus? Especially if you think about the fact that, as Ioannidis has argued, that most published research findings are false, right? Should one RCT really produce consensus? On the topic of how much disagreement is enough, how much equipoise is enough, a number that you'll run into in the literature is 70-30. a 70-30 split, meaning that if 70% or more of the population of physicians believe that treatment A is better than treatment B, then equipoise does not exist around that question and a trial should not be done. You might be interested to know where that statistic comes from. It comes from a bunch of researchers who walked into a bar. I kid you not, this is real research. It was published almost 30 years ago in the Journal of Medical Ethics. They surveyed patrons of a public house, bridge players in that house, Italians who were in that public house, nurses, neighbors, medical students, and came up with this number of 70-30, whereby about 50% of respondents thought that a trial would be unethical if that threshold were met. High quality research. So, what is equipoise? Well, it seems to mean at least two different things. If equipoise is the standard we use to determine whether a given RCT is scientifically necessary, which is a big part of determining if it is ethically permissible, but it has many different meanings, and it's not clear how to operationalize it, or it's too easy a threshold to cross, then is it any standard at all? We thought it was appropriate to rethink the ethics of clinical trial justification and look deeper into this problem. And so we conducted two important studies. Well, studies I hope will end up being important. We conducted a mixed methods review, which was essentially a systematic review of reasons given to justify RCTs. So we call it mixed methods because the analysis was really very qualitative, though we applied standard systematic review methodology to identify all of those statements that we could in the literature that pertain to the justification of clinical trials. Any statement that said something along the lines of, a trial is justified if, a trial is justified when, a trial is not justified, blah, blah, blah. And we identified 1,300 different text excerpts including these statements. We then coded those statements into themes and identified 16 different themes, 16 different reasons, 10 of which accounted for 99% of the text excerpts, and the majority of which related the justification of an RCT somehow to uncertainty, either uncertainty of a physician community, uncertainty of individuals, uncertainty in the literature, or just some reference to uncertainty. What about equipoise? Well, equipoise was looked at as one of a series of keywords. So we didn't say that equipoise was a concept, but it was a term that could be associated with these different reasons. And it was a very commonly used term in relation to many different reasons, including individual MD uncertainty, uncertainty of a community, evidence-based uncertainty, uncertainty not otherwise specified, the patient's best interest. So based on our systematic review, we identified a significant heterogeneity of reasons given to justify RCTs, and a significant heterogeneity of definitions applied to this concept of equipoise. We then conducted a series of interviews with physician researchers, philosophers of science, bioethicists, research ethics boards, chairs, and we sought to invite members from regulatory agencies, though no one would speak to us. We asked the 45 respondents from the first three groups a set of standard questions about the reasons to conduct RCTs and definitions of equipoise, etc., and this is what we found. They defined equipoise 7 different ways. 2 respondents could not define it. 1 research ethics board chair had never heard of it. And we got a lot of responses like this. I remember when I first heard it and I didn't know what it meant. And I asked someone what it meant and they gave me an answer. And I asked someone else and they gave me a totally different answer. Among the reasons given, the most common definition matched with Friedman's clinical equipoise, so uncertainty at the level of an MD community, but this was by no means the majority. We also asked respondents how they would operationalize equipoise, meaning how would they act out to identify if equipoise existed around a particular question. We had 7 different operationalizations. The most common response was that they would establish whether equipoise existed based on some literature review, though this answer was only put forward by a third of our respondents. Others said it was a question of the vote of the Research Ethics Board. They would ask their peers. They would ask the principal investigator of the study that was being assessed by the Research Ethics Board. And no particular threshold of 70-30 or 80-20 was put forward at any point by our respondents. One very interesting response was that the Research Ethics Boards deferred to the principal investigator of a study, the person who's most implicated in making sure that the study succeed and be accepted and be activated, to determine if equipoise existed. And one of those PIs said this: well, I think it's like any scenario. You're making an argument. Your thesis is that there is equipoise, and then you have to go out and convince people that there is. So at least that principal investigator recognized that one of his roles was to convince people that his trial was ethically justified. And Research Ethics Boards deferred to the PI for that judgment. So what did we learn from these two studies? There is no single reason for RCT justification. There is no single definition of equipoise. This produces a number of problems. One is a problem of transparency. The two people may be talking about equipoise and be meaning two completely different things. And an REB may assume that when the PI says there is equipoise, that he means that there has been a systematic review of the literature done, when in reality he's just saying that he personally is undecided. This lack of transparency and this heterogeneity also produces a problem of fairness, because it could mean that two trials are being judged by different standards, very differentially rigorous standards, right? It's very different to say that whether I have uncertainty versus whether a systematic review of the literature really demonstrates that a certain question has not been answered. It is also possible that the same trial is being evaluated differently in different locations, and therefore patients are either being deprived or exposed to the risk of the trial inconsistently. Finally, the deferral by ethics boards to the study's director or PI to determine if equipoise actually is met is a problem that allows for the potential for self-dealing or conflict of interest, or at least a circular logic. Therefore, I think what you should take from this is that there is no clear standard by which RCTs can fairly, transparently, and rigorously be considered justified or not in the current environment. And that if we are expecting equipoise to do that work, it really is not able to serve the purpose of a high standard, and maybe we should abandon equipoise entirely. Or at least move beyond it. Because I think there is a nugget of truth there. There is something that is helpful, at least in its relation to uncertainty. Right? We heard over and over again that a big component of determining if a trial is justified is whether there is uncertainty. That's great. But in a paper that we published 5 years ago now, we argue that uncertainty is not enough. There is always uncertainty. This is a notion from philosophy called fallibility or fallibilism. There is always uncertainty. Our knowledge is always incomplete and imperfect and evolving. Therefore, if establishing uncertainty is all it takes to justify an RCT, then this is a very weak standard and any RCT would be acceptable. So we need something more than uncertainty. So in 2017, we proposed a 3-step test, of which an assessment of uncertainty was just one part. Is there evidence-based uncertainty around the research question? So for us, uncertainty needed to be established through some kind of review of the literature. It wasn't good enough just to say whether I personally believe that it is not clear if treatment A is better than treatment B. Ground your assessment of uncertainty in the literature. Make that an evidence-based assessment. Secondly, ask, are all the treatment arms scientifically plausible? Meaning that is the patient unlikely to be deprived of an effective treatment for the purpose of randomization, right? What we're getting at with this question is that a trial that, for example, randomizes a novel treatment against placebo when there are actually standard options available, that would be problematic, and it would be problematic on the basis of question 2. Finally, and this is where we're going beyond the issue of uncertainty, is there needs to be an assessment that the trial is sufficiently rigorous to be able to contribute to our knowledge. Not that it's going to lead to consensus necessarily, because we know that is unlikely to happen, but that we're going to be able to at least interpret and use the available findings of that study. So the sample size needs to be, well justified. The recruitment strategy needs to be appropriate. The study should be sufficiently feasible and generalizable that we could apply its results more broadly. What this third element relates to is a concept that I think will be quite familiar to all of you who are doing meta research on randomized trials, is that a badly done trial is a wasteful trial. A lot of trials, unfortunately, are badly done and are wasteful. And a wasteful trial is in itself an unethical trial. It wastes resources, it exposes patients to risk for no good reason. More recently, we put forward another concept that we call the 4 quadrants. So yes, this is borrowed from Star Trek. The idea is this, that the kind of comparison you are running, the kind of treatments that you are comparing in your trial will determine to some degree the epistemic standard, the evidence-based standard that is relevant to your comparison. So I think we were looking too broadly in our work about the 3-step test, because that's not necessarily going to be relevant to all potential RCTs. It's really most relevant to what we call alpha quadrant RCTs, where you're comparing 2 approved treatments. Right? 2 different antihypertensives, they're both approved, they've both been shown to be somewhat effective, they're on the market, and you're comparing them to see which one is better. In that circumstance, right, a systematic review of the literature is likely to give you very useful results. Both of the treatments will be plausible, and you just got to design the study well enough. But what about if you're dealing with a beta quadrant study where you're comparing a novel treatment to a standard of care? So this is where you'd imagine a cancer situation in which you have an established protocol for treatment of leukemia, and now you're doing your established protocol plus a new, in humans, monoclonal antibody. A systematic review is really not likely going to tell you very much. The opinion of experts in the field is probably not going to tell you very much because everybody's going to want the study result to be positive. And so the evidence that is actually going to be most relevant might actually be evidence pertaining to the risks associated with the novel treatment rather than the benefits. What about in a gamma quadrant situation, you've got a novel treatment versus a placebo. So this is a condition in which there is no standard treatment. For example, in my world, acute intracerebral hemorrhage, and you're now randomizing patients to receive a novel procoagulant drug. Again, first in humans, or at least at the level of a phase 2 or phase 3 RCT, you're really not going to have a systematic a large literature to systematically review. Individual physician opinion is not really going to be relevant. So it's going to be a question about, again, the evidence that is most relevant is going to be looking at the risks of the treatment and the risks of the condition left untreated. Lastly is the scenario where you've got a standard treatment that perhaps has become widely accepted but has limited evidence for its efficacy, and it is being tested against its absence, against the withdrawal. Really, that is the circumstance in which we had the ESCAPE trial, right? It really was not an alpha quadrant circumstance. It was a delta quadrant circumstance. And in this scenario, what is, again, perhaps most relevant is definitely not the opinions of the experts in the community, because they're going to be quite used to that standard. Right? You're going to have to look at non-randomized data. That's the evidence that might be most useful. Historical controls, and be, fundamentally skeptical about your approach to the adoption of treatments in the absence of high quality evidence. Last slide, what are the take-home points? This concept of equipoise is thrown around as being very important to the ethics of clinical trials and evidence-based research. I would argue that it's a term that's used in relation to many different concepts, and as a consequence, It's not a clear standard. It's not a strong standard. It's an inconsistent and non-transparent standard, and we need to do better. The ethical justification of RCTs is a real problem for evidence-based research, and it's a problem that can be answered, or at least through which we can advance more useful answers through, I think, the methods and the processes that all of you are interested in terms of meta-research, and considering more broadly the questions of what count as evidence and how do we ensure that our research is evidence-based. I thank you all for your patience. I thank my colleagues, trainees, supervisors, supporters, funders for their support over the last few years. Thank you.
Thank you so much, Michel. Very, very interesting and relevant topic. We have planned it so that we also will give Alex an opportunity to share his presentation, and then we will have a common discussion among the two of you and all the participants. So thank you again, Michel, very interesting. And Alex Sutton, I'm happy to introduce you. You are professor of medical statistics on the University of Leicester in the United Kingdom. You have a long-standing interest in methods for evidence synthesis, as well as work on designing future studies to update meta-analysis. And you will share that with us today. And recent work includes developing improved visualizations for evidence synthesis results and online software for network meta-analysis. Also very interesting, I think. But I think that's the statistical approach to what we are talking about is something that is really worthwhile to discuss. So thank you for joining us, and the time is yours. Thank you, Alex.
Hello, everybody. I'm very happy to have been invited to talk at the first evidence-based research conference. In fact, I consider it an honor, and I wish both the society and the conference itself greater success going forward. I've been asked to talk on this title, When is a Further Clinical Trial Justified? And I'll try to keep to topic over the next 30 minutes. I give my email address there if anybody wants to get in contact with me, and I encourage you to do so if you're interested in this work. That would be great. And before moving on, I just want to acknowledge my many co-authors over the years, too numerous to mention, but they know who they are, that have contributed to the work that I'm presenting here today. So you know where I'm coming from. I'll just give you very briefly some details of my background. I'm a medical statistician. I've been working mainly in evidence synthesis for over 25 years. This includes both substantive applied reviews and working in the methodology. And one of the strands of methodology I've been interested in is working towards ways of making more explicit and helpful recommendations for future research to be included in systematic reviews and meta-analysis. I became conscious that I was writing things like more research required, and saw other people writing similar things in recommendations for research in systematic reviews, and realized this really wasn't very satisfactory, and we really should try and be more explicit. And a lot of what I will say going forward is how I've tried to improve that situation. I want to start by just thinking about why we do evidence synthesis and systematic review. And here I have a quote from the Cochrane collaboration, and they say their aim is to gather and summarize the best evidence from research to help you make informed choices about treatment. And obviously these go a long way to underpinning the principles of evidence-based medicine. And within systematic reviews, there's commonly meta-analysis, which is a statistically rigorous approach to estimate treatment effects. One advantage of doing meta-analysis is it has increased power over individual study results, and it also gives us some capacity to quantify and explore heterogeneity. And by heterogeneity, I mean the variability in treatment effects between trials, and this is certainly something I'll return to as the talk progresses. I want to go back some way in time now. This is just before my career started, and this was a very influential paper then. It looked at the trial evidence for some important treatments. In this case, in these pictures, it's treatments for myocardial infarction. And it pointed out that if meta-analysis had been carried out, that effective treatments for saving lives would have been identified more than a decade before they were commonly used and seen in textbooks. And we see the right plot is the cumulative effect of synthesizing the trials, and we see that by about 6 trials down, there's already overwhelming statistical evidence that the treatment is effective, but it took a lot more trials and a lot more years before this became routine practice. So we note in '92, hugely influential paper on getting people to do meta-analysis and summarize the best evidence that's currently available for treatments to get them into practice quickly. Little was said really about the wastage in primary research, but clearly I think a lot of us would agree, even back then, this is very influential and persuasive to suggest that perhaps not all those sequences of trials were needed, and some of the latter trials were in fact not required. So jumping forward 17 years, and this is a paper published in The Lancet, Avoidable Waste in the Production and Reporting of Research Evidence. And it estimated that 85% of all health research is being avoidably wasted due to studies being underpublished or poorly published, and new studies were frequently being developed without a systematic examination of previous research on the same questions, and therefore included avoidable flaws. And it was around this time that I got interested in the area, and I think this brought into focus a lot of the topics that are discussed at this conference on making research more evidence-based to reduce wastage. It was around this time that I got involved in the first piece of work in this area, where we looked at Cochrane reviews where new studies had been added, but we could establish that a systematic review in the area had existed even when the studies that had been added were being designed, and therefore there was a systematic review available for the study trialists to actually go back and look at. And we actually asked such trialists, and out of the responses we got a message that only about 1/3 of them looked at a Cochrane or similar systematic review when designing trials. So much room for improvement, and I hope things have improved already since then. This is 2005. Well, I hope this slide raises the odd smile, and I hope it doesn't offend anyone either. But this is how I saw the situation at the time, and to be honest, I still think much can be done to improve this, where on the left we have trialists, and I sort of see them as doing unique novel work, but maybe a bit too much in isolation. And then on the other side we have the reviewers, and they have a reputation of just chucking everything in together without maybe as much rigor as they should to make sure studies are similar enough to come to meaningful conclusions, etc. And I think systematic reviews have improved over time and been more explicit in their inclusion criteria, making them more interpretable. But I just want to point out that anything this conference can do to help this communication, I think, would be a bonus. And in my view, then there needs to be a much more back and forth dialogue between these groups of people, and that would improve the situation. This is a diagram that no doubt many of you will have seen. This hierarchy of evidence, I'm never quite sure who takes credit for creating this, but the important thing is at the top we have systematic reviews and meta-analysis, presumably of well-conducted randomized trials being at the top of the hierarchy, closely followed by individual randomized controlled double-blind studies. Nothing too controversial there. But when you think about making recommendations, I got into the following argument, and it's still persuasive for me today and drives a lot of what I'm about to say. So when new primary research is carried out, we should consider its likely impact on the existing meta-analysis. That seems a reasonable thing to do, given that that's most likely going to sit at the top of the hierarchy in that area. So that seems a reasonable thing to do. That also implies, of course, that the updated meta-analysis will have more impact than the results of a trial reported separately, because it's higher up in the hierarchy. But when we design studies and think about sample size and power calculations to make sure the trial is sufficiently big, we usually relate this to the analysis of the new trial on its own and not the impact of the existing evidence base. And I'm arguing that there's some incoherence here. Shouldn't we be thinking about the impact of a study on the whole systematic review and the updated meta-analysis, the totality of the evidence? And that is the standpoint I'm going to take for the rest of my talk. And indeed, most of what I'm going to say now is going to focus actually on just deciding on when we need new studies and when we need them, what sample size a future trial should have based on updating an existing meta-analysis. So let's look at an example meta-analysis to motivate some of the thinking in this area. Here we have oral appliances for sleep apnea. And on this plot, we have 4 small dots which each represent an individual study, and a diamond at the top which represents the pooled estimate from a meta-analysis of those 4 studies, and the uncertainty in that pooled estimate represented by the extremes of the diamond. So we have our treatment effect on the horizontal scale, and also on the vertical scale I've got standard error going from 0 to the top downwards. So it shows the precision of individual studies, and we can see that the most precise one nearest the diamond has a standard error of something like 0.16. We see that the diamond at the top has a positive result. We have a result of 0.55, but the confidence interval includes both negative and positive numbers and crosses the 0 line of no effect. So we would say at the 5% level, certainly, this treatment is not statistically significantly beneficial. So the next thing I'm going to show you is regions of that scatter plot where a new study would have to be for that meta-analysis result turns to a statistically significant result at the 5% level. So I'm not going to give you the technical details of how this is done, but here is the plot, and you can see the 3 coloured areas shaded. The sort of light pink colour in the middle is the area where, if a new study existed, i.e. that combination of effect size and standard error or accuracy of result, the result wouldn't change, it would still be statistically non-significant. If the trial was in the bluey-green area to the right, then we would get a statistically significant benefit of the new treatment. And if it was in the orangey-red to the left, we'd actually get a result going in the other direction. So we note that would be a statistically significant harm of the new treatment compared to continuous positive airway pressure. So we could get the result going either way, but obviously we'd have to have quite a lot more precise a study to get the result to going harmful, because the existing evidence is suggesting a benefit overall. So just to further explain and emphasize what's going on here, imagine where the crosshair is on the border between the green-blue and the light pinky area. A study was conducted and it got a result there. Well, if that was the case, you would get the meta-analysis updated to the white diamond at the top, and what we see there is obviously still a positive result, but this time that 95% confidence interval just touches that no effect, or it's on the border of being significant or not, because the study is on the border any further into that greeny blue area and we would get a result away from the 0 line. So this plot would sort of says where the study would need to go, and we can see there's studies already been observed in that greeny blue area. So I think it would be quite plausible for one new study to change the conclusions of this meta-analysis, and I see no reason why we shouldn't think about doing that study. I should say before I move on that all that I'm going to show you assumes that we have faith in the meta-analysis, that it is producing an unbiased effect size, and summarizes the current evidence about the treatment effects that we're wishing to estimate more precisely. We can move away from statistical significance to think about clinical significance, and if we are willing to define minimal clinically beneficial effect sizes, then we can also look at the impact of new studies on establishing such criteria. And this is work that was done in collaboration with people interested in the effect of exercise on reducing back pain. We can see the existing meta-analysis here, and while there looks like there's a benefit of exercise, it's unclear whether it's clinically worthwhile. Clearly, it's not going to result in a -30 improvement in back pain. There's a chance it will result in a -20, and if we focus on that as the smallest worthwhile effect, we can produce contours showing where the study would have to be to change the conclusion. And if we look at this plot in the top right hand corner, which is the same format as the ones you've been looking at, we see the blue area is the area where that study would have to be, and the red area that would still not be a conclusive result. Just moving that on a stage, if we make an assumption, we can translate the standard error into what the sample size per group will be, and we can plot that contour plot in the second plot there in the bottom right hand corner. We can see again for the sorts of sample sizes of studies that have already been done, it is possible for those conclusions to change. So moving from these plots, which I think are quite intuitive and give an understanding of the ideas I'm trying to put forward, we can now move and think about how we'd actually estimate the power of a new trial to update and change the conclusions of a meta-analysis, be it statistical or based on clinical effect sizes. Now, when we did this work, I'm using that example here, I sort of groaned because I tried to get something simple, but it's certainly controversial. We looked at the time, and I know it's changed since then. It's quite a while ago now. The Cochrane review on antibiotics for common cold. I think there's a general established that antibiotics are ineffective for a common cold, but please kind of dispel that kind of belief and just imagine this to be a more abstract idea that there is a treatment effect here that looks as though it could have a modest effect. But there's certainly not definitive, and the diamond here is crossing this pooled result. We're not significant at the 5% level. So the question I'm asking is, what study would we need to do to have reasonable power to establish whether this treatment works or not, when the new study would be updating the meta-analysis, not analysing it on its own as we typically do. So if people aren't interested in the technical details of this, you can snooze for a couple of slides, but for those that are, I'm going to quickly go over the procedure. We estimate power by simulation method. Certainly I'm not sure how the equations for this would be derived. We essentially simulate a new study, predicting the result in it from the existing meta-analysis, and we generate that study, and we then pick a sample size for it, generate the data from it, add it to the meta-analysis, and see whether it changes the conclusions. So if we're thinking about statistical significance, is the updated meta-analysis significant or not? We make a note of this. Then we'd repeat this ideally a large number of times, several hundred or thousands, and we just count the number of times the conclusions of the meta-analysis change, and that gives us our level of power. As simple as that. So I'm just going to go through that with our example here. We do our meta-analysis, get our pooled result with an effect size that crosses 1. We simulate a new study. Don't worry about the variable names there if it links in with a paper if you're really interested in the details. Simulate outcomes for the patients in the 2 groups. And we redo the meta-analysis, adding the new study in. We'll get a zoom up of that here. So there's the new study at the bottom in red, the simulated one. We've updated the meta-analysis, and actually this study didn't change the conclusions of the meta-analysis. You can see the test for the treatment effect still has a p-value that's greater than 0.05. So this would be one iteration, and we'd consider this not to have changed conclusions. If we repeat this a large number of times, I'm doing it 1,000 times, it actually turned out that 304 out of those 1,000, the result would become statistically significant. So we could say for the sample size I chose, which is 200 patients in each group, in each arm of the trial, we have approximately 30% power to change the conclusions of the meta-analysis. And of course, we know we probably don't want to do a trial that has 30% power, so we'd probably want to increase the sample size, and we can then iteratively try different sample sizes until we get one that has the desired level of power to update the meta-analysis. And here's a power curve from that analysis. So we see that to get up to power of 80%, which is often seen for individual trials, we need a whopping 4,000 people in each arm of the trial, huge and much larger than any of the existing trials. We also have the result we observed for a power 30 at 200 people. We note as well that this starts to kind of get difficult to get much above 80% power, because there's 15% of the time we're going to actually simulate a treatment effect that says the treatment's harmful and would actually pull the result in the other direction. So that's why we get something sort of tapering off to the 85% irrespective of size. And just to give you an idea of how this relates compared to power on its own, if you analyze the new study on its own, we can see that this fixed effect meta-analysis has moderately more power than analyzing the study on its own, which might be intuitive given that you've got some evidence already to suggest it's beneficial, and we're adding to that rather than starting anew and analyzing the new trial on its own. Now, on the last slide, I used a word that I've not really explained, and I need to do that now. I said that was a fixed effects meta-analysis. And that kind of analysis assumes that all the studies are estimating the same treatment effect. Often we don't believe that because of the inherent nature and variability between different trials that are done. We'd expect some variability in treatment effects, and people have argued that we should include random effect in the modeling of the meta-analysis to allow for this variability between trials, real variability in treatment effects, often called heterogeneity. And you'll see I've estimated what the heterogeneity is. That is what we're calling tau squared, 0.11. And what I'm going to show now is if we relax this assumption and make a less strong assumption and say there's variability in effects and use a random effect model, how that affects our power. We see that actually I've put on what's called a predictive distribution here, which is showing that because there's variability, the prediction for a new trial is wider than the diamond of the pool effects here. We're actually saying it can vary by a lot more than that. That's not me putting that on in a sense. That's the implication of the random effect for predicting an effect in a new study. Okay, so this is where this work went from being kind of interesting to me to being, oh gosh, I didn't see this coming. And you will see what we have there is the two power curves that we've already talked about. One from the meta-analysis, the dotted red, and the blue solid line just below it is the power of the study on its own. What I wasn't anticipating was seeing this at the bottom, which is essentially saying for any number of subjects, and I've done for up to 50,000 here in each arm, that meta-analysis has essentially zero power or very close to it to change its conclusions. So one new study, irrespective of size, will not change the conclusions of the meta-analysis. And at first I thought this was a mistake, but no, if you work through the maths of it, it isn't actually a mistake. And this is where things become kind of important, I think, and non-intuitive. So just linking in the two ideas I've shown, if we go back and look at what the contours would look like for the random effects, we see that they're kind of radically different in a sense here. We only have this one little area where things will change up at the top, where you have to have a precise effect. Why don't we have things over in the more extreme treatment effects? Well, what happens there is that the heterogeneity gets larger if we estimated a treatment effect over there, which would further actually reduce power. So this heterogeneity thing is a big issue, and this kind of confirms why we have problems updating the meta-analysis to get a decisive result. Well, I said at the beginning of the talk I was a statistician, and I think I've done pretty well at not giving you any equations until now, and this is the only equation in the talk, and it only has two things in it. We're talking about the weight that each study gets in a meta-analysis, and in a random effect model, the weighting is 1 over the study variance plus the between study heterogeneity. In a fixed effect model, the between study heterogeneity is 0, so it's just 1 over the study variance. So essentially, as a trial's study variance gets close to 0, as it gets infinitely large, the weighting can get infinitely large and have infinite influence in a meta-analysis. Not so for a random effect model, because it's limited by the degree of between study heterogeneity. Even if the study variance goes to essentially 0 by being a massive trial, the weighting is limited and it's still 1 over the between study heterogeneity. So this is why it may be impossible to get 100% power with the addition of a new study, or any power at all, because of this limiting factor of the amount of heterogeneity. This comes to a suggestion that maybe multiple small studies are desirable, and of course that goes against a lot of common thinking in this area, but that's how the maths plays out if you want to use random effect models. I think to get past this, we have to ask what is causing the heterogeneity, and if we really identifying the cause is crucial for interpreting the evidence. It should be a priority. And here are 3 common reasons it could be difference. It could be true differences in the intervention, i.e. the timing, the intensity, the dose, the expertise of the people administering it. So there are truly different treatment effects based on characteristics. If we can identify those, then we can start to unpick this. It could be due to different populations in the trials, and the characteristics of the populations interact with the intervention. It could be disease severity, age, ethnicity, etc. And we may want to again unpick, and we get to different treatment effects for different characteristics, and we can unpick this variability in effects. But possibly just as likely, it could be caused by imperfections in study design, conduct, and reporting. And again, this is a very different situation. We could possibly, if we think it's this, adjust for it, but that's pretty difficult and in very much in the experimental stages in meta-analysis. Sorry, this slide's a bit cramped, but it's an important one. Unfortunately, most of the time we can't unpick this heterogeneity. And of course, as the unexplainable heterogeneity increases, the meta-analysis is increasingly difficult to translate into routine clinical practice. What does this distribution of effects mean? It's not uncommon for both beneficial and harmful effects to be contained within the distribution of effects. If we don't know what causes the variability of these extremes, how can we recommend it and to whom? So how do we make recommendations for future trials when there's an explained heterogeneity in the existing trials? Unfortunately, I don't have a good answer to that question at this point. something I've been thinking about is, are we best to wipe the slate clean? Or reduce the evidence base to the best quality, the most similar trials? By wiping clean, I mean start again, learn from the mistakes, and start a new series of trials. Remember that any existing heterogeneity will downweight the contribution of future trials to a meta-analysis. And it may actually be more efficient to start again, but obviously we have to have some agreement about that, which is a big issue. Adding new good evidence to an interpretal mess still results in a mess, unfortunately, which is the alternative. I've yet to publish that suggestion, and I'm trying to work out a palatable way of suggesting it. But I'm not apologetic that this method I'm proposing fails. It's not really a failure of the method, it's a failure of not being able to explain the current situation with what's going on in the existing trials. I think often we plough forward without knowing this, and really it kind of forces this dialogue to exist before new research is done, and that in itself I think is a good thing. And really I think we should be describing how a new trial will fit in with an existing base before it's done. It should be there in the protocol and when in the application. Very briefly, I just want to talk about a few extensions and complications as we move forward with these methods. The first is, the more I work in this area, the more I see that a lot of the time there are ongoing trials as well as the existing meta-analysis. This complicates the situation, but the methods can deal with this. They can simulate the potential results of those ongoing trials as well as the new ones. So it's just more work is required, not that this is a sticking point. Extremely quickly, we just want to flag that there's network meta-analysis, which usually compares all relevant treatments in an area and has gained a lot of popularity. We can again extend the methods to this kind of situation, and the first papers thinking about this are appearing. So it's a more complicated situation than the pairwise meta-analysis I've described in this talk, but again, not an unsurmountable challenge. Oh, very briefly, when you update a meta-analysis, there's this idea that you're doing multiple testing, and we all know that's a bad idea because it increases the risk of false positives, and people are talking about methods to address updated meta-analysis to deal with this problem. And certainly there's the possibility of merging those methods with these to make sure that when we design a new trial, we also adjust the power level from repeated looks at the existing evidence. So briefly, to sum up, I think there's much scope to improve how previous evidence is used to design and prioritize future research. But methods are in their infancy and are little used in practice. We're probably, due to their added complexity, there is some resistance to their use, and I think software would need to be improved before they can have widespread uptake. But there is much work to be done and experience to be gained, and I think the time is right for this, and I think you are all very well placed to engage and make the necessary progress if you think this is a worthwhile way forward. And as I said at the beginning, I'd ideally like to talk to any of you who are interested. Thank you again.
Thank you very much, Alex. Very interesting and very challenging. I must say, as a chair leading the coming discussion, is rather challenging because at least I have, I don't know, maybe 2 pages of questions for you here. But I think the interesting thing is, and that's our intention actually, to ask the two of you to be in the same session. You have very different approaches, but you are both having the same basic question. When do we know that a systematic review is stable? Meaning, when do we know what to do with the patient, or when do we know, and another way to put the question, when do we know that we don't need any further research on this particular aspect of the clinical situation here? And we have one statistical approach, and we have a more philosophical approach. So I don't know, maybe Michel, you should have the chance first just to think, how could those 2 approaches be combined? Do you think that they would make sense to combine? Do they fit into your three steps, or what you call it, 3 criteria you mentioned?
Thank you very much. Can you hear me?
Yes. Yes.
Great. Alex, thank you so much. That was really interesting. And to the extent that I'm not a statistician, I think I followed pretty well. And I have a project in mind that I think we could propose. We've been looking for some methodological help. So there you go, already a success for this venture. With regards to the question of how to handle existing data and moving forward, I think there's a lot of synergy. And really that first question of ours of there needs to be some kind of systematic review of existing literature before asking the next question, I think is essential. And obviously we're not the only ones to say that. Dr. Lund and Glasgow and Chalmers and et cetera, et cetera. One of the questions that was written, and I'd like to bring in this as an example of how that method could work, is the question I brought up about the 3 RCTs showing no benefit for endovascular thrombectomy, and then the next generation of RCTs showing benefit. How could it be that happened was one of the questions. I think one of the issues, which you hit the nail on the head, was heterogeneity in terms of the intervention. So part of the issue was that this was an evolving field and the technology was developing. So not all of the comparisons were exactly of the same intervention, right? And when you're dealing with a procedural intervention, that's very challenging to standardize in the same way as a pharmacological intervention. And so I think that's one issue. The other issue, though, to bring up is that there had been no systematic review of all published data, either randomized or non-randomized, prior to the advocates, including the ones I was working with, saying we need to do another trial. And so I think that was a failing. And I think we would all have said, if we've got a standard that has developed, it's a clinical practice that is common, but there's variable or heterogeneous literature, let us try to do some kind of systematic review before saying that we need to do another RCT. And interestingly, something that I've been wanting to do, and I finally had somebody who could had the time to do it with us, we just did that review. We did a review of the literature of EVT pre-2013 and post-2013, including randomized and non-randomized data. And interestingly, as your example about beta blockers, if a review had been done in 2012 of data available, it would have been positive. And interestingly, not only that it would have been positive, but the magnitude of the effect size is actually quite comparable to the effect size of the post-2013 interventions. And so I don't think we would have been off very much or have had an overinflation of benefit for the inclusion of non-randomized data. Some thoughts?
Yeah, very good. Alex, what's your thinking of the 2 presentations combined and answering the question is, when is a systematic review stable?
Well, Hans, I think you've been deviously brilliant, because I asked for an advice cite of Michael's talk just out of interest. And ever since I've lost sleep wondering, was I going to be asked the question, explain the things that agree and disagree and the consistencies between the talks. And I'm still trying to process that. At no point in Michael's talk was I sort of shaking my head or saying, oh gosh, no, that's at odds with what I'm suggesting. As you said, we're really just in 2 rather different frameworks, actually, pulling in the same direction. And as I said about the sort of the people doing reviews and those doing individual studies, and somebody earlier in the day talked about those doing basic science and those doing science in humans, it's bridging these gaps and working sort of in a more holistic way, I think, that's going to really have to knock this out. So, I support everything Michael said, and it certainly needs more thought to integrate this. I said I was coming from this, only from the statistical point of view here, and I didn't think about ethics in my talk. That doesn't mean it's not important. It's just I'm not the person to talk about that, and it is only each of these are only one slice of the bigger picture.
So maybe that was your answer to my next question to you. In the situation where you're not able actually to perform a meta-analysis, what then you do?
Yeah, well, it's a good question. I mean, all this depends on having confidence in your evidence base. So if I may just pick up on a trend in some of the questions, it's what happens if there's publication bias? What happens if the early trials are biased? And also what happens if there are no trials at all? Or, people are looking more and more to observational data. And I think that's the best you can do. If you're being, and without going too heavy here, if you're a Bayesian statistician, you have prior beliefs before you do something, and then you do your study and then you update those prior beliefs. So I was predicting effects out of a meta-analysis for a new study. They could come out of a meta-analysis of the observational, but not to add the observational to the trials. There's always some sort of I see this quite consistent within the Bayesian paradigm of updating of expertise. I mean, Michael's example was interesting, how the observational was pretty similar to the trial. Of course, there has been historically the pathological kind of examples like magnesium, where the opposite happened, where the first 5 or 6 trials were all enthusiastic and looked good. There was a mega trial that showed it was harmful or certainly not effective. And nobody's really reconciled why that was the case, although we seem to generally believe the mega trial and not the 6 early optimistics. And unfortunately, there's always that thought at the back of the mind, this is good until it isn't, if you like. And that's a really difficult question to answer. It's almost unanswerable, I think.
Michel, I was thinking about considering your 3 criteria, the evidence-based uncertainty, the scientific plausibility. I guess that's the underpinning research you're thinking of there, and a valid study or scientific rigor of the study. What about value, as Rieke van der Graaf mentioned this morning? Maybe, I don't know if you had the chance in the middle of the night to join, but she was clearly stating very strongly that the value of a study is very important, the societal value, the relevance for the end users. Would that be a 4th criteria you could add, or have you included that in the 3 criteria?
That's a great question, and I apologize, I wasn't there this morning. I'm actually on call, so I'm wearing my hospital things. I'm on the stroke service today and over the weekend, so hours are challenging. I think the issue of value is, I am very sympathetic to that view. The way that I think about it is, we've been talking about this word justification, and I think that can be broken down really more explicitly into 2 bits. So necessity and permissibility. So by necessity means, do we need to do this? And that's the value question. What does asking this question add value to society? And that would be a separate question. And then under, is this specific trial permissible? Then that's where we get to the 3 questions. So the answer of the necessity is value, and then the permissibility is the more, methodological. Are we asking the right question? Has that question already been answered? And is the technique appropriate? And
then you can use the statistical approach.
And that's right.
Yeah. So you have the value, you have the 3 criteria, and you have the very nice statistical approach Alex have presented. Would that make sense to the 2 of you?
Yes, very much.
But then I have another question for you, Alex, because the way I was thinking, I was reminded about the Cochrane Scientific Committee. They made a short note in 2018 dealing with exactly this question of whether a systematic review is stable, and they clearly, in my reading of the note at least, it was a rejection of the frequency approach, or the what you could call it, the frequency approach. That this is really including the trial sequential analysis and all other kind of sequential analysis mentioned. What do you think of that related to your analysis or the simulations you have done?
Yeah, so there's a few things to say there. We'll take trial sequential analysis, and I followed that discussion as well, because it's a very interesting one. Everything I've done doesn't take that into account. So what you're going to do is get these, as you update and do more studies, and then have to do more and more, your multiple testing and your p-values are askew because of the lack of independence of these tests. So if I put my Bayesian hat on, we don't worry about such things as a Bayesian. That doesn't mean they go away. It just means I don't care about them. All I want is to know today what's the best. So it runs deep into research, and I'm not going to get into a frequentist Bayesian. I don't think that's helpful. So certainly that's true. I mean, we've actually looked at using these methods to work out when to update systematic reviews, because if you think about, rather than just saying, oh, well, we're going to do a new study with 500 people in it, you can actually say, we know there's a study with 500 people and then one with 200 people that have been done. Is it worth the effort of updating it? What's the likelihood? And if you run that on a portfolio, you can prioritize. And somebody very cleverly for an MSc project actually programmed all this in, and we took an area of Cochrane and sort of piloted it. And that wasn't ultimately recommended by Cochrane, but it fed into some of those discussions on updating as well. So, yeah, I mean, obviously, I'm kind of putting it forward because I can't think of a better way of doing it. It's just you come into these problems where you get very different results with fixed and random effects, but that's kind of forcing you to explain why the studies are differing before they start. And I think that's the true, whether you're Bayesian or frequentist in how you look at things. I think that's the kind of key thing. The other things are important, but they're details around the edge of this in comparison to the heterogeneity.
There was a question here by Camis Alessi, actually two. I'll take one first, Camis. In light of the global pressure on scientists and researchers to accelerate the introduction of effective intervention to stop COVID-19 pandemic on the expense of ethical standards and conduction of systematic reviews before undertaking RCTs. I think maybe the two of you both have a comment to that question.
Alex, do you want to go first, since it was
the
please, question was addressed to you? Or?
Okay, I'll take it first. Well, I think the COVID thing's quite unique, and I have thought about it quite a lot. You know, we now have, I believe, it's probably out of date. A couple of months ago, there was about 1,000 trials registered and about 200 systematic reviews, and everyone's doing it. But how much order and organisation is there is dubious. And I'm making things worse. I can shamefully plug and put a link probably to an online meta-analysis where we did for 5 months, updated the trial evidence, and you could explore it within an interactive viewer. I mean, it's a difficult one because it's a bit of an unusual evidence base in the sense that people are trying just about anything that could plausibly work, and so in that sense, knowing it's not like the building so much on previous trials sometimes, and you know, these things are done quickly. It's a really interesting one. I'm going to pass this to Michael. I think this I'm struggling on this, but in a sense, what I'm saying is, we couldn't wait systematically to do a systematic review to try the next treatment. I think there could have been more cooperation, but ultimately, I think getting trials done in this area where we knew so little was possibly not crazy. Just it could have, with hindsight, it could be more organisation.
Michel?
Yeah, so I've been thinking about this a bit too, and I cut these slides out of the talk because we ran over time. I think the first thing to say is this is not the time to abandon or weaken our ethical standards. If anything, it's very important to strengthen them because of the fact that there is so much political and economic pressure to approve treatments that we need to be as certain as we can be that we are not at least harming patients. And the patients themselves also will be, they're, you know, very vulnerable. And, you know, you ask somebody who's admitted to a hospital with COVID-19, no family around, they're going to get intubated, they're going to be unconscious. Do you want to participate in a trial of a new and promising drug? Who's going to say no, really, right? That's where really we need an infrastructure that will ensure that there's at least a certain amount of reasonability of the treatment. For me, this is kind of a, we call it our beta quadrant study, right? This is a novel treatment for a condition that never existed before. So we have no basis from which to draw a systematic review on existing treatments. Yeah. Really, there is value in a systematic review of the risks of treatments if there's things that are already available out there. But efficacy stuff, you're not going to have any information. So it's really a question of the risk of the added intervention. But then I think there is an ongoing onus on the researchers to contribute to some kind of organized integration of the available literature as studies are being completed. So we've done it. We've looked at this as well. There's based on our review there, for example, there are 206 RCTs of hydroxychloroquine in different circumstances, about 320 different vaccine trials that are ongoing. So, very large numbers. Does that seem logical? I think that that's probably inefficient. I think it's probably wasteful to some degree. You want reproducibility, but maybe 206 trials is a bit over the top. And then there's also the question of the ethical justification. In that, as we are accumulating a literature to say, for example, that hydroxychloroquine is ineffective, at some point, some integration of that literature would say, okay, we've answered that question, let's move on, let's stop enrolling patients into trials, let's stop launching new trials. And yet, unfortunately, I think that that is not happening systematically, rigorously, right? Some trials are saying, okay, so there's 80 some trials that have been abandoned, and some of them are abandoning because they can't find patients. Some of them are abandoning because they say, well, we've got accumulating evidence. So why is it that that evidence base is being reviewed and considered so inconsistently? If we've got a systematic answer, and maybe the answer is Alex's website, then that should be consistently followed and integrated into research planning. So there's definitely a problem of coordination.
But maybe just a thought, and the two of you asking the two of you, do you think in this case, let's say COVID-19 as an example, a very good example, we should much more look at harms and risk rather than effects, much more.
Yes.
That would really be the one we are doing the meta-analysis upon and not the effects.
I mean, I think that at least with regards to choosing interventions, that makes a lot of sense. The concern is, of course, that there's not only direct harms to the patient of running a trial of hydroxychloroquine, for example, right? Mm-hmm. There's the cost, there's the opportunity cost of those interventions, and then of the fact that other patients who require those medications for valid reasons are being deprived of access, which is never going to be captured by a review of just the harms to those individual enrolled patients. If that makes sense.
Alex?
Yeah, I'm not clinically trained at all, so I'm going to be cautious on what I say. But one thing I did cut out my talk that was relevant to this is that the health economists have had a thought about these kind of areas for a while, and there's a whole theory called value of information analysis, and they kind of put all outcomes in terms of money, the cost of the treatments, the benefits of the treatment, the harms of the treatment, and the likely length of benefit you get if the treatment is identified as being beneficial. So what I showed today was what I call value of information for WIMPs. It's about 10 times easier to calculate, but takes about a tenth of the stuff into account, but it's still a lump beyond what is typically done on a trial. And if what I'm discussing ends up as being a halfway house, and we eventually get even more sophisticated, well, great, but it just seems there's such a void between what they call the EVI, the expected value of information stuff the economists are doing, and the typical trialists, that there needs to be some bridging gaps or stepping stones towards that. But these other methods would allow all outcomes to be considered simultaneously and coherently.
I mean, I was looking for another aspect here, and of course I know, Michel, you haven't had the opportunity to listen to one of the abstracts today, but Jung-Wook Ban was making a point that you could talk about waste as an extreme case of inefficiency. Mm-hmm. So maybe this could also be a concept or a thinking that could be helpful in the COVID-19 situation. I mean, COVID-19 is a, if you may excuse me, a lovely example of how to deal with exactly the questions we are discussing today. So maybe the way he put it is that inefficiency of a study, it's really on a continuum. But the waste is in the extreme of this, and what is the limit, and maybe the inefficiency of the study could be an argument against performing the study. If you could say something about inefficiency before that, of course, in the design and the planning. I don't know if you have any comments, Michel.
Hearing that for the first time, I mean, that sounds very reasonable. I think I'm sympathetic to that view. I mean, if we want to have reproducible science, we're going to need to do some things over in ways that are redundant to some degree. So you need a little bit of inefficiency, need a little bit of doing something twice, and the most extreme form of that becomes unnecessary. I mean, I wonder if there is, again, a statistical boundary point where, and that's exactly what we've been talking about, right? Yeah. Where accumulating more evidence is unnecessary, where the systematic review is stable. I've not come across that concept before, that term, but I really like that. I think that captures a lot of what we're talking about.
I mean, one of the positive things that is happening here is there are living systematic reviews. So there are websites that are updating the COVID evidence and network mesh analyses of all the trials basically on a daily basis. And what I would say is that anyone that's doing primary research needs to be looking at that. And even, we've not really got mechanisms yet, but ultimately I'd even think trial monitoring should be looking at that and making decisions. Is the trial still ethical to continue? Because we're in a different world than we were when you started that trial. And, we're not, I don't know much about review boards of trials, but I suspect it's much more dynamic a situation now than they typically have to deal with. But ideally that should be considered.
I agree. And certainly my experience, having been on review boards that are reviewing COVID-related research, there's a huge bias towards allowing them and letting them happen quickly, because we know that there's a time crunch. And I have not seen forward a systematic review of available knowledge as of yet. Now, maybe this was kind of May, June, so perhaps we didn't have a lot of that available yet by that time. Things were still new, but it's reassuring that these things have developed in the interim.
I'd just like to shamelessly add that I've given a link to the app, and that has nothing to do with designing the next study, but it does allow you to explore the COVID evidence base. It ran for 5 months, it's just finished, so we're not updating it anymore. Ultimately, we'd like to build in a module that would then allow you to explore throughout this network, doing any comparators and the power you'd need, and doing what you'd expect in the next study, etc., along the lines of my talk. And obviously that's work going forward.
I can see there's more questions here related to our discussion, but the time is up, unfortunately. But just to remind everyone, and also you, Alex and Michel, that we will save all the questions and comments, and we will ask you as presenters to give you a written answer to all the questions, so we have this and can share that on our website. But thank you very much for two very interesting and provoking presentations. And thank you for a very good discussion. And see you all tomorrow at 9:30 for the next session in our conference. Thank you. Have a nice night. Bye-bye.
Thank you.